Hello everyone. Welcome to another episode of Dental Digest with the Study Booths. This is Dr. Trehan and today we will move on to our next topic in oral pathology odontogenic cyst series talking about calcifying odontogenic cysts. Now we will start with basics, where these cysts come from, how they develop, clinical features, radiographical features, histopath, possible complications, then the differential diagnosis, and then onto the treatment option. Now COC is also called as Gorlin cyst, and there is one unique feature of this cyst. That is, the COC can present itself either in a cystic form or in a solid form. So basically, COC does not always behave like a typical cyst. Sometimes it shows features that really resemble a tumor as well. Now let's talk about the origin and etiology. The calcifying odontogenic cyst originates from reduced enamel epithelium, or you can say cell rests of dental lamina. Let's talk about the clinical features. This cyst is commonly found in the second to fourth decades of life. Usually it doesn't cause any symptoms, but when symptoms do appear, swelling is the most common feature to see. Pain or discomfort can also occur, but it is very rare. Now, in some cases, the cyst can also lead to delayed tooth eruption or even tooth displacement. And if the lesion gets large, it could result in cortical plate perforation. This is important. Now, there are two types of presentations to note: intraosseous and extraosseous one. Now, the intraosseous lesions occur within the jawbone and typically cause a very firm, hard, bony expansion. And on the other hand, extraosseous lesions, they are found in the soft tissue and they appear as pink, or you can say red, elevated swellings on the gingiva. Let's discuss the radiographical features of calcifying odontogenic cyst. Now, this cyst, it appears as a unilocular radiolucency with a small radio-opaque flex inside, which gives it a unique salt and pepper appearance. In some cases, it may even present as a multilocular radiolucency. Now, the borders, they are typically well defined and it can also be associated with that of impacted teeth. Now, a standout feature of this cyst is presence of calcified ghost cells. And these calcifications create radio-opaque spots within the radiolucency. Now let's talk a little bit about the histopathology of calcifying odontogenic cyst. So the lining of this cyst has a basal layer that is made up of columnar or cuboidal cells which are arranged in a palisaded pattern. And these cells have dark, or you can say hyperchromatic nuclei. Now the hallmark feature of the lesion, as we talked about, is ghost cells. And these are keratinized cells that no longer have any nuclei in it, which gives them a clear ghost-like appearance. And now these ghost cells undergo calcification, leading to small chalky deposits which are known as dystrophic calcifications. Now occasionally the basal layer of the cyst, it shows budding, which tells us its ability to grow. And in some rare cases, even melanin deposits can be found. So this cyst has variable appearances. Now let's go over the complications of calcifying odontogenic cyst. The most common complication that we have already discussed in the clinical features is that this cyst can get secondarily infected, which can lead to swelling and pain. And then the bone resorption, tooth displacement, and delayed eruption can also occur. So then there is also a possibility of malignant transformation of this cyst to a ghost cell odontogenic carcinoma. And this complication is very, very rare, but when it happens, it's a serious one. Now let's discuss the differential diagnosis of COC, which includes various conditions like ameloblastoma, dentigerous cyst, odontoma, odontogenic keratocyst, and ghost cell odontogenic carcinoma. So the first one is ameloblastoma. Now both ameloblastomas and COCs, they present as a radiolucent lesion with occasional radiopaque features. However, if you notice clearly, COCs are less aggressive and they tend to show ghost cells histologically, as we have talked about, and these are absent in ameloblastomas. Also, ameloblastomas have a multilocular radiolucency, whereas COCs are most commonly unilocular. Now let's discuss dentigerous cyst. Both COCs and dentigerous cysts can be associated with impacted teeth, but the key differentiator is that dentigerous cysts do not have ghost cells and these calcifications, which are very clearly present in COC. Now also, dentigerous cyst has its lining attached to CEJ. So we can clearly differentiate between dentigerous cysts and COC. Now let's move on to odontoma. Now COCs and odontomas, both of them show calcified elements. However, the odontomas, they consist of organized tooth-like structures, or you can say amorphous calcifications, whereas COCs, they present ghost cells and scattered calcifications within the cystic or solid lesion. Then we have odontogenic keratocyst or OKCs. Now OKCs, they resemble COCs in their radiographic appearance, particularly if they have a multilocular radiolucency or they're associated with impacted teeth. But if you notice clearly, OKCs, they lack radio-opaque flecks, or you can say ghost cells, as it is seen in COCs. Additionally, OKCs have a characteristic thin parakeratinized epithelium, while COCs have a thicker epithelial lining with ghost cells and possible dystrophic calcification. And lastly, we have ghost cell odontogenic carcinoma or GCOC. Now, this is a malignant counterpart of the COC, and it shares features like ghost cells, but it is differentiated by a number of features. Like GCOC, it shows aggressive behavior, invasion into the surrounding tissues, and even metastatic potential. So just by focusing on ghost cells, calcifications, and epithelial linings' distinct characteristics, the COC can be reliably distinguished from these other odontogenic lesions. Now let's talk about the treatment options for COC. Now for smaller lesions, enucleation combined with curettage is the usual approach. This means surgically removing the cyst and carefully scraping the surrounding tissues to ensure no residual cells are left behind. But for larger or more aggressive lesions, resection may be required. And this involves removing not just the lesion, but also a small margin of the surrounding healthy tissue to reduce the risk of recurrence. So let's quickly sum up the calcifying odontogenic cyst. So this is a rare lesion which is also called as Gorlin cyst. It arises from reduced enamel epithelium or dental lamina remnants. It typically occurs in second to fourth decades of life, then appearing as a well-defined radiolucency with calcified flecks and a strong association with that of impacted teeth. Histologically, we have talked about ghost cells, palisaded basal cell layer, dystrophic calcifications, and while these are generally asymptomatic, it can cause swelling, delayed tooth eruption, and rarely cortical plate perforation or even malignant transformation. In the treatment, we talked about enucleation and curettage for smaller cysts, and for larger ones, we have talked about resection. Then we talked about how we have to differentiate it from similar lesions like ameloblastomas, dentigerous cysts, odontomas, and this is key for accurate diagnosis and management. Thank you so much for watching this episode. Now, if you found this video helpful, give it a thumbs up and subscribe to the channel for more content. Let me know your thoughts or questions in the comments below, and I would love to hear from you. Remember to keep working hard and keep rocking. I'll see you in the next one.